Yeah, the lack of quarterback is a problem because it's inconsistent. And we've been recognized nationally as a best practice relative to quarterbacks situation because it takes it out of the hands because they have the triage criteria.
Yeah.
Mm-hmm.
So if the triage criteria is met,
Sure.
they call it, except in the rare situations where a discretionary aspect to this because one of the EM physicians takes the call or something like that. The reason it's a best practice is it allows us to clearly, if we're going to change the triage criteria because it's not working or it's being called too often or it's associated with more serious and serious need for more resources, we can change it because we can monitor it, and that's the problem. The other thing is, my biggest critique of our system is the fact that we have almost too many triage criteria.
There's a lot.
Yeah, and it's overwhelming, and nobody can manage. So that's why the quarterback having it open and available. But we're loading it up. The American College of Surgeons verification process only requires 6 parameters for, and they're all physiologic parameters for relative to triage to the highest level of care. Only 6, and they're not mechanistic.
Oh, correct me if I'm wrong. Those are the ones that are technically like our full activation criteria, or closest to that.
They require full activation, and they require the surgeon to be there within 15 minutes or 30 minutes in a level 3. But there are only 6 of those criteria.
Yeah,
and
that's a good point.
But when we load up that initial response, now you're making somebody who is a community general surgeon has to come in when really our EM physicians often are more than capable of doing that. So and we probably have to take a critical look at that going forward. Fortunately, we've never lost. We haven't lost a trauma surgeon. But early in my career, when I was a resident, I was on call for trauma, and my attending didn't come in, and then he came in dead.
God.
He got sick. He ran a red light. He ran a stop sign and got sideswiped.
Oh wow!
I got T-boned, and he came in. He wasn't dead. He came in DOA. I worked him, and he died. But
wow.
Yeah, that just went through my mind, and I always think about that when I think about triage, because he was coming in for something that I probably, I was a chief resident, and I would have taken care of it. I didn't need my attending there.
Wow.
Well, we talk about that from an operational standpoint in EMS about, do you really need to run lights and sirens? And Caleb brings it up and talks a lot about it, and I talk to my guys that lights and sirens means things aren't going as planned in the back and you actually need to get there in time, but 99% of the time it's just going to put you and your patient at higher risk running hot.
Yeah, and you had that accident of a rig.
Oh, South Central Ambulance when they were hit, actually transporting to Geauga, and the provider in the back presented, I believe, at the Knott's Symposium, right?
Yes, he did.
Front yard.
Huh?
That was in my front yard.
Yeah, and I mean, he was severely injured.
Yeah. Bad head injury. He's recovered, but a remarkable recovery. But he was out for a week, and I'm sure he has long-term. He's returned evidently. What's his name again?
Jesse.
Yeah.
Jesse.
Yeah. I mean, he gave a great talk of recovery, because it's not the initial hospitalization. He didn't even remember the initial hospitalization, but it's the impact on his wife and his
family.
And his family. I mean, and his crew.
Sure. That's traumatizing
you know,
to them.
It was enormously traumatizing, and they did a great job of extricating him. But his patient in the back of that ambulance died because of it. And this was a drunk driver who ran the stop sign. But anyways, that's a long. I haven't thought about that case when I talked about my attending not surviving. And I think we used to drive in for response time. I did it myself early on in the before they made the 15-minute rule that required it. It pretty much required. As a matter of fact, I wrote a paper that debunked the 15-minute rule. It made no difference. Coming in 15 minutes made no difference in outcome.
Yeah.
If you came in at 30, it just doesn't make that much of a difference as
Sure.
long as you're there.
Well, and even logistically, how quickly can you get an OR available to get the patient to the OR?
Well, yeah, and that's they want it's all trying to push the needle, and the 15-minute rule was to get us to stay in house.
Sure.
Yeah, to be there.
Yeah, and that was because it was common, especially in the academic trauma centers, the very academic trauma centers. They would never come in. The attending would never come in. It was chief residents.
Yep.
That were doing that. So, a senior resident, you're in this kind of a 7-year program, and you're a chief resident. You're already, pretty competent in almost anything, including operating. And the attendant come in, look over my shoulder, and say, "Yeah, you got this. Yeah, you can go." Yeah.
Well, speaking about ambulances and transport decisions, so for trauma patients for EMS, I think dovetails this into that. So, we talk about whether we want to transport our patient by ground or by air, right? And then we also want to talk about your scene time is a big thing I think pre-hospital we want to discuss. So if, the way I've always looked at it is if I can get to the hospital faster than the aircraft can get to me, that's a higher level of care, right? So if I am 5 minutes from Geauga or 6 minutes from Geauga, I can get there. There's secure the resources, secure the emergency room physician. Doesn't necessarily mean that patient might stay there, but Geauga County is a great example. Just like Portage, I don't have another essentially option at the moment, so I could go there. They can secure air, but let's go out to, like you discussed, like South Central. That's actually where I grew up, was out in Ashtabula County in the Rome area. Now I'm 30 to 45 minutes probably safely from any hospital, right? That might change the game of, instead of my patient going by ground, maybe I need to secure that air asset. That could be, if UH AirMed could be to us in 10 minutes, and they're going to be able to get that patient to maybe a level 1 trauma center in the next 10 to 12 or 15-minute flight, right? So I think that's a big thing we need to talk about is like transport decision. Am I going ground by air? And then also I think loops into that is how long are we going to stay on scene, right? Because I think, I don't want to put the cart before the horse, but I think sometimes as EMS providers, we need to prioritize, and I'll kind of use your language a little bit, Dr. Tinkoff, I'll change it, is what life-saving measures do I need to perform right now before the ambulance starts moving? Let's say we're going by ground, and then I need the ambulance to start moving to a destination.
Yeah, don't stay and play.
Yeah.
Be moving to make the decision and be moving to the place where that decision needs to be made. I think air versus ground is time distance. So knowing time distance in the geography of the area and understanding weather as well.
Sure.
Like today, you're not going to get people flying, so you be aware of during your shift of those environmental concerns and the time distance relationships of all this. And so for a shift like on a day like today, you're going to Geauga. Or you're going to Portage. You have to be. If you're in Ashtabula County that's now we have the lake system that's available to that. Or if you have to, a non-trauma center is fine if it has an EM service, and an ED service, and and they're in the UH system. We'll move them fairly quickly.
Because one of the big things that hospitals have that, at least right now, EMS doesn't, is blood.
Well, so that was what I was going to say. In the case for me of a extrication or a farm equipment incident or somebody entrapped with hemorrhage, a big part to me is even if I call for air medical, it might just be for blood product.
Sure.
I might not need them to transport, but
Correct. The resources on the aircraft, that's
resources
huge.
alone. I mean, maybe I can't get an airway and I still have somebody entrapped. At least I can get resources coming. We're fortunate that, we've talked about it before. We're an RSI department. We've utilized it once in 2 years. It's not like we're using it every day, but in that case, we do have some of those resources, but we still don't have blood product.
Correct.
So,
That's
but
great.
most places don't do RSI.
Right.
So if you have a critically injured patient who you're expecting a 30-minute extrication process,
you may need
that aircraft.
You might want to call aircraft just for extra. You get extra hands, more advanced hands.
Sure.
You get RSI, and you'll get blood products.
well, and that's it too. You don't necessarily have to fly the patient.
No, they're
I've
happy to
had
hop you
lots
in
of
the back
times
of
where
an
they've
ambulance. Yep.
jumped in our squad with us and just been hands, and it's been great.
Yeah, that's a good point too, to think about it. Like, they're going to bring other resources, right? Other medications. So if you do know you have that long extrication, and then off camera we were kind of talking about extrication, since we're still kind of covering some of the scene things, is just because your patient is trapped in the vehicle doesn't mean treatment cannot occur, right? You might be able to reach an arm and start an IV, or reach an arm and get a blood pressure, even if I could just palp the blood pressure, right? Or
If they've got a radial pulse, they've got
Sure.
a reasonable blood pressure, right?
Right. Yeah. So like basing it off of those things, and then I think on a documentation standpoint, we also talked about this is if I'm sure most dispatch centers, just like ours, and Caleb, I'm sure yours is the same. We have on scene, we have an entrapped patient, extrication has started, that's time stamped. Patient has been removed from the vehicle, successfully extricated, time stamped. So now I could say in my EPCR, which is important to the receiving center, hey, it took 30 some minutes to cut him out. I could also take a picture of that said car, truck, tractor, whatever, and attach it into the EPCR. So that's something that the emergency room physician could see, something that the surgeon could see, and it's just that continuation of care.
Yeah.
And that also lets us know, how long they were in there, right?
We had a
So I
case
think it's huge.
at my hospital where they called the aircraft there, and I think as they extricated the patient, they went into cardiac arrest. Makes sense. You are now releasing anything that you're holding off tamponading, right? They
Yeah.
get them out. They go into cardiac arrest. They're not going to fly that cardiac arrest.
Correct.
We're not going to be able to fit a Lucas device inside the aircraft. You're going to load that patient up into the ambulance, transport by ground, helicopter will follow. But you're going to, at that point, they're in the middle of northern Portage County. They're going to come to us because we were closer than even going to Geauga because we're the closest. At that point, it's time, right? It's getting to a more advanced place that we can intervene on. They're full activation. Fortunately, we did not get them back, but if we did get them back and stabilized, I've now got a helicopter sitting right outside that can airlift the patient to CMC.
Right. And somebody that unstable, what justice are you doing sending them to a level 1 anyways when what they really need is
An airway.
Yeah. Then we go back to the
Airway,
ABCs.
and then they need resuscitative measures, including if there is hemorrhage blood.
Yeah, and that's
the
what,
one thing I always get most stuck on is that we call our farthest transport for us, we're lucky, it's about 8-9 minutes. Our closest is 3 to 4 minutes, and we're at the hospital. So for me, a lot of times, unless I'm stuck extricating somewhere, we're going to meet the helicopter at the hospital. They have a landing pad. It's secured. It's better. Security and police are there to help with that. And then if something happens on the way, we're going to divert right to the ED, and they can meet them inside and help too. So, I wish more people could use that benefit, but not everybody has that luxury.
Well, on the west side in our network of level 3s, Elyria, who has is often been used just for that, is meeting EMS at their LZ and taking off from there and moving them into one of the level 1s, generally Cleveland Medical Center, but also Metro Health, and making sure that they're moving. appropriately. More often than not, they're going inside though for evaluation purposes.
Yeah,
There's some law there too. I mean,
Correct. So you're on the hospital's property.
Yeah.
So I do want to talk about this a little bit because I think this is a
Well, but that's been integrated within the structure of the EMS community there.
correct.
Yeah.
yeah. And I think best practice, not to interrupt you, Caleb, but best practices, and this was kind of our practice at Portage for, John knows this goes way back. I would always tell him, yeah, you can utilize the helipad, right? But if you pull in with said trauma patient, you do not see the
not
aircraft
see
on
the
the ground.
aircraft.
It's not there. Then you need to go in. So a notification still needs to be prompt to the hospital, early notification. Tell them what you're doing. Right, there's going to be an aircraft coming to said hospital. Right, that's
We
huge.
get very freaked out
When a helicopter just
when we get
lands.
a call from air ops to get a helicopter landing. Well, why? I don't know. I didn't call them. It kind of freaks us out. And
Yeah,
so,
but what happens if they have to all of a sudden come to you and you
Sure.
had no idea? I mean, I could understand that.
because we get transfers out too that they might
Right.
go by helicopter. So it's us trying to figure out where is this patient coming from? Is it coming from ground and it's going to go out that way, or is it someone that just had a cath and now they're on an Impella and they need to go up by aircraft?
I agree. And I tell my guys routinely that if we call for a helicopter and we're utilizing the helipad strictly as a helipad, you got to still call the ED and tell them that we're going to be rendezvousing
Yes.
there in case something
Yeah, and
happens.
our transfer center is educated.
Yes.
In that.
Yeah, and they do a great job at it.
Yeah.
Yeah,
Yeah,
actually,
but
the transfer center's great.
I think the big thing is, though, just to the MS provider takeaway point is if you pull in and that aircraft's not sitting there, that's why the notification is important to the hospital, because you do not want to sit in a parking lot for whatever reason. There, let's say a delay happened, right? The resources are right there. You're staring at them. You need to do what's best for your patient, and you need to take them into the building and get them those resources, and then emergency room and trauma can figure out if the patient needs to transfer, if they need to transfer by air. That aircraft's then there. That's okay. It could still be utilized, but don't. It's not best practice to sit there and just wait for 15 minutes, especially if your patient is critical. Go in the doors,
Ohio
get help.
law doesn't say you should; it says you shall, and we have trauma triage that we shall meet. And when it says things like "shall," that's now law. So we have to meet those standards. Also, we can't.
Yeah. I just think we've had some, not we, but we've known
There's been
of cases
yeah.
in the past where EMS has camped and waited for the helicopter when they could look at the emergency room doors, and then there were bad outcomes. Not in our system, but I mean, we've read case studies from across the country where that's not a good practice. So I thought it was good to talk about that. So I think we've talked a lot about, priorities, transport decisions, air. We've kind of covered that. Things you need to get before you transport. Obviously, if you want to get a good set of vitals, perform any life-saving measures. If you're going by ground, then
Those life-saving measures are going to be make sure they're an entrapped patient, you can typically needle decompress them, whether that's, if you can't get anterior access, that's why I have axillary access.
Yep.
Start an IV in those patients. You can start the resuscitation even though they're entrapped. If you've got great training or want to attempt, you can even tomahawk them, use your video-assisted laryngoscopy device, and you can even drop ET tubes in with patients sitting up.
Yes.
That's one of the things I prefer to even intubate patients sitting up. I don't do my trauma patients because they're typically lying flat. But if I'm electively intubating a patient, I actually like to do it 30 and 45 degrees. So you can do it. Something you can even practice, like put your mannequin up and attack them from anteriorly or even from up and behind, so you get used to doing that. Even
And AirTrack has an option to flip the camera 180 degrees too, which is awesome.
Yeah. And we've actually hosted some of those trainings. I'll have to plug Middlefield Fire Department for that. Captain Tony Europoli and UH AirMed, we've hosted those trainings where they've put a mannequin in a car, flipped it upside down, and then been like, get in the car and intubate the patient,
Absolutely.
right? Outside of the box practice and tips, but it worked out really well. All right, I think this is going to kind of lead into what is our big thing, since we're talking about trauma, would be trauma's lethal triad, right? So what is going to kill our trauma patient? All right, so we talk about acidosis, we talk about coagulopathy, and then we also talk about hypothermia, right? And John, you hit on the one item, bringing the patient into the ER. We have all these different resources. I think the low-hanging fruit here is, I'm going to start with hypothermia, if that's okay. In your car
season.
Yeah, 'tis the season, right? It's snowing out. It's very cold. Yesterday it was 60 degrees. Today it's 32 and snowing.
I think, yeah.
So it's like big shift, and I think a lot of times we Some of it is our environment. It's not a great time to keep them. It's difficult to keep a patient warm. You have a lot more resources in the emergency room to keep that patient warm. But other times, I think people underrate hypothermia in the trauma patient. My example would be it's 98 degrees outside, and now you cut that patient out of said car, and then you put them in your ambulance. What's the first thing we do? Well, we cut all their clothes off because we want to expose them, and I want to do my
and we're hot from extricating, so we turn on the air conditioning.
Correct. In the back of the ambulance, the temperature's set to 62 or 64 or
As
however
cold as
low
it- as cold as it can
cold
go.
as the air conditioning can go. Meanwhile, you're like, why is this patient shivering? It's 98 degrees outside,
Yeah.
right? So
They're
we have
freezing.
to be cognizant of that low-hanging fruit. Yes, you need to expose them and do a good exam, but then you need to return and immediately cover them back up and keep them warm. It doesn't matter if it's 98 degrees outside or it's 34 degrees outside.
And I tell my medic students, if you're hot, it's a good start. Turn on the heat now.
Yeah.
Yeah, we generally keep the trauma bays at 80. And that's, we
Even
realize,
in the peds world, they keep them even hotter.
yeah, well,
crank
we
them in
realize
90s.
basically the bleeding patient will go to the ambient room temperature. So they're going to start at 90. If they're starting at 98.6, they're going to drop temperature pretty quickly to critical hypothermia. So basically, we need to warm them. And it's a major principle. Obviously, it's the E of A, B, C, D, and E.
Yeah.
Yeah.
And so that's why when we expose them, they're getting after we do our primary and secondary, they're getting covered up with warm blankets, and then they're getting escorted over to the CAT scanner with their warm blankets on them.
All right, let's talk about coagulopathy. Maybe that'll go hand in hand with hypothermia, right? So as we get our patient that's very, very cold,
Yeah.
that we are not keeping warm,
Yeah.
then our ability to clot would decline, right? Which causes an increase of bleeding, increased risk of bleeding, or in theory, we're just not addressing it.
Remember those in the coagulation cascade, those are temperature dependent processes, and once they become that cold, you do not clot. All right, and so that's why there's a triad. They feed off each other.
Sure.
Yeah.
Right, and then if we can't oxygenate our patient, or if we are not perfusing our patient, maybe they're declining hemodynamically, and those items, we start to get a buildup of, obviously, we can get into acidosis.
Right, and that's that's basically the triangle of death.
Yeah.
And it's hard to overcome that unless you address it early in the resuscitation, i.e., you want to oxygenate,
Sure.
right, and resuscitate,
Yeah.
all right, and then move toward basically warming the patient.
The amazing part is, even at a basic EMS level, we can conquer all three of those things. So it's not anything magic here.
No, it's not mad.
And we know one of the rules of trauma should be that we expose the patient and look for hidden injury, right? But in doing so, again, we're freezing them. We need to then warm them up.
Yep, cover them back up. And I mean, I think a lot of this stuff is basic. We even talk about, and we've taught pre-hospital, and I think it's going to kind of dovetail into the TXA item as we talk about a lot of the basic functions that we've learned from essentially war, right? What has killed our soldiers, unfortunately. We talk about hypovolemic shock, right? Because bleeding that's uncontrolled, well, we can do direct pressure, where obviously we can put a tourniquet on. Stop the bleeding is a BLS EMT skill, right? I need to stop the bleeding. Or if it's in some type of a junction, then we want to pack the junction. If they have some type of injury open, then we want to seal the box, right? We want to do a chest seal. If we can do direct pressure, stop it, or a tourniquet. And then we also get into other items would be like an unsecured airway. Well, maybe we need to ventilate the patient. Maybe we need to intubate the patient. We need to put that patient on end-tidal CO2. That's going to give me a live feed of how they're perfusing, right?
Yeah, the problem with the intubation, though, is especially if you're going to use your RSI, you're taking the patient's ability to breathe away, and you have to be very mindful of that.
Sure.
If the patient is maintaining their own airway, keep it. And
Correct.
Just maintain it, and let the decisions be made, support that patient with oxygenation. I've seen, especially with RSI, real tragedies occur.
Oh yeah.
Sure. I like the way you said that. It's kind of like don't overcomplicate it, right?
Yeah.
Well,
Would that
right,
be
right.
you know,
But-
if they have a patent airway, it's open,
Yeah.
I can just supplement some oxygen, then I'm going to move on to B. How's their breathing, equal chest rise and fall, good lung sounds,
the
just
body was
don't
built
complicate it.
to really save itself in a lot of ways, and if
Yeah.
we impede the ability to save itself, you're not helping.
And remember, permissive hypotension in the bleeding patient until control is whatever control, external control you can provide. But the patient, if a patient has a blood pressure and a pulse and is still breathing, get them to us.
Yeah.
Right?
Yeah.
Yeah, absolutely.
I had a patient in residency that they increased blood pressure a little bit too big because we didn't have blood pressure control, and they ended up dying because of it. Because we were trying to treat a number and not the patient.
Sure.
So, again, permissive, have us make that because we're trying to thread the needle almost with this, that I'm going to be okay, and we have this even with our respiratory patients. We're sometimes even allow hypercarbia, not in trauma patients, in our respiratory patients because they're just kind of used to being hypercarbic. These trauma patients, they're critically ill, and we're going to thread that needle that I'm going to be okay with a little bit softer blood pressures as long as they're especially maintaining and they're stable as they can
Yeah.
be.
When I'm in the trauma bay, as the attending, and there's a team leader, my job's supervisory. But one of the things I do is I touch the patient, do a capillary refill on the fingers and toes, in a pulse check. And if they have a pulse, it's 80. If they have capillary refill, it's probably about 60. So only. And it's in that range. I'm fine as long as we're moving through the primary survey and doing the things that we need to do to resuscitate the patient. And don't get overzealous, and I don't necessarily need an airway at that time. I need to maintain them.
Yeah.
If they, basically. That whole process of intubation, especially in penetrating trauma, can be life-threatening. And I'd rather do that in the operating room, getting ready to arrest the hemorrhage, if I can.
I think two things are so important that were kind of mentioned here. One was treat your patient, not your monitors. Put your hands on the patient. Know your patient, right? And two is, basic airway adjuncts are not bad, even at a paramedic or physician level.
That's right.
Nasal pharyngeals, how often do you see them anymore? Not really often, for whatever reason.
Well, the head injury issue is
That
always
is an issue.
Yeah.
Oral pharyngeals even, but basic BVM techniques.
Yeah, good ventilatory techniques.
Yeah.
We can control bleeding with
Jaw
basic
thrust.
techniques.
Yep.
I'd say one of the
Process goes
ALS
a long way.
One of the ALS techniques would be good to mention, like you brought up, how we won't fly a traumatic cardiac arrest, or if you have a traumatic cardiac arrest, one of the first things we need to immediately be ruling out as part of your H's and T's is we need bilateral needle decompression, right? Whether it's midclavicular or midaxillary, those need to happen. We teach a lot of these same trauma techniques in TECC, right? So a lot of the stuff that we're reviewing, we talked a lot about with Joe Sugar, who's the head of our tactical EMS division, and we talked about a lot of those treatments. It's pretty much similar. We talked about TXA a little bit earlier. I kind of want to loop back to that. So obviously we have TXA in our protocol. We talk about some of the indications of them, the patient showing us that they have sustained tachycardia, heart rate greater than 120, or they're showing you that hypotensiveness, they have blood pressure less than 90, they have that traumatic injury. They're deemed an adult trauma patient, right? So they are greater than 16 or the age of greater than 16. And we want to give TXA within the first 60 minutes from time of injury, because we know with science and the studies show the farther out you essentially get, your morbidity and mortality increase the further away you get away from the injury. And it's pretty easy. It's 1 gram in a 10 ml vial. And we can give it 2 ways, right? So we can either mix it in the 100 bag. We can draw up the 2 grams of TXA, inject it into the 100 ml bag of D5. And as pharmacy doesn't like the word shake, so we're going to use introvert back and forth. Yes. Shake lightly. And then use your 10-drop drip set, and we want to give that TXA over the course of 10 minutes. or you can draw it, and then we have headed a. Did that get headed this year? Was the
It was last year.
Last year was the 2 gram push over the 10-minute period, but
You can also give it topically for epistaxis.
yeah, so it's used for a lot of other good
It
things,
is,
right? So Dr. Hill, you talk about that a lot.
I do. I'm a big proponent of that for nosebleeds. But from a trauma standpoint, I think that, and it's come up in recent discussions with places, is that if there's either current evidence or you have previous uncontrolled hemorrhage, if there's a big pile of blood on the floor and maybe you've got a tourniquet on now, but they're hypotensive, they probably benefit from that TXA. And that's my belief. I don't believe that it's going to be, and we talked about this earlier, it's not throwing clots into the patient's body. They're going to benefit from that drug. They should get that drug, and you should take them to a trauma center and leave that tourniquet on and make sure you write down the time it happened. But if there's prior concerns of this, there's obviously some massive injury that we want to add the TXA on to help stabilize the clots that are formed.
That's a good way to talk about it, because I think a lot of people get confused on how TXA works, right? It's not just like dripping clots down the drip set, right? No. So when you cut yourself, and correct me if I'm wrong, because you're both way smarter than me, but when you cut yourself, well, you too, sorry, Caleb, you too, sorry. When you're bleeding, you get a buildup of fibrin and plasma. We get the buildup of fibrin and plasma, and it's trying to fix itself, right? To your point, it tries to fix itself, and those clots are likely to break down.
They are breaking down. The natural process is to break them down and build them back up.
So that TXA comes in and just essentially tries to make those clots firmer, so they do not break down, which could then stop the bleeding, right? But it's not like if it was dripping clots down the drip set here, we would have a stroke, a PE, we would have a heart attack, right? We'd have those different things at the same time.
It's antifibrinolysis. Fibrinolysis is what it's doing, and that lysis of clot is or fibrin of a clot. So it's preventing that and making sure that the site of injury, if arresting hemorrhage can occur, it will occur as the clot integrates. Can it cause thromboembolism? Probably. It can, and that's the concern, and that's a controversy with it. But right now, it's integrated into early bleeding and the management of early bleeding. I would point out that it's integrated into all our massive transfusion policies.
Yep. Yes.
Across the system. So it is part of that. So if you in the field, if your patient's bleeding and continues to bleed while we have them, they're going to go under a massive transfusion protocol and it will be activated.
Sure.
And that they're going to get that anyway. It's very important to communicate that the patient has been given TXA
to the receiving facility.
That's right.
Yeah, no, that's huge. Yeah, because that the resources that you have at your center, mass transfusion protocol, blood products, right? Whereas we're just utilizing either normal saline or lactated ringers that does not carry red blood cells or oxygenated blood. So that's just
matter of fact, crystalloid should be minimized.
Yeah, because we don't want to cause fluid washout, breakdown of clots, dilution.
Yeah.
That's bad, right?
Yep, that was a big learning that I took away from when I did my ATLS recertification. That had changed.
Yes, very much so.
To limit fluids, and I'm reaching for blood products sooner.
Yes.
Because you guys are already going to start IVs. Hopefully, it's bilateral IVs. You're going to have a liter of fluid rolling, and if they're rolling and they're still hypotensive, my next step is blood.
Yeah, but we're taught almost contrary. I mean, unless you're smart about it, like I said earlier about the pH levels. If I have holes in somebody and I'm leaking, I'm going to plug the holes and then I'm going to fill you back full of fluid. But saline's not the best product for that. Blood is. So we have to be careful about that. Unfortunately, to this day, I think that the issue is probably price difference between lactated rainers and normal saline, and that's why we give one over the other. And I wish that all squads only carried lactated rainers. It's just a better product in most cases. But maybe you can enlighten me there.
I take pause with head injuries and lactated ringers versus normal saline.
Yeah.
So
no, not only pause. It really that's the indication. If it's an isolated hand injury, that use saline.
Yes.
But again, low volumes. If you don't need it for blood pressure management, low volumes are indicated.
Yeah.
250 and probably no more.
Yeah, just trying to maintain that map
Yeah.
of 65,
Yeah,
right?
right,
Like
right,
my
right.
goal is just to maintain 90, right? I don't need to make it.
Unless
I
you
don't
have
need to
act-
make it 110.
Unless you have active bleeding, and then it's permissive
Sure.
hypotension.
Sure. Yeah, but we don't want to exceed that, right?
We're not talking about head injury. Head injury and bleeding are one of the most difficult patient subtypes.
Yeah.
And,
Yeah.
Cushing's triad,
Yeah,
such.
yeah, and you're basically that requires a high level of care, but resuscitative measures have to be ongoing, and you have to stop the bleeding to save the brain.
Gotcha.
And the other thing to think about is if we had that in the box, because we have to think pharmacologically, there's a lot of things that'll participate, that'll come out of solution inside of LR that doesn't happen in normal saline. So normal saline is a safer medication from that standpoint. If you're talking about pushing drugs through that
That's
line,
right.
those lines.
That's a good
So
point.
from a limited standpoint of the 15 minutes of care that you guys have, I personally think a liter of normal saline, normal pasta water is probably safer and better. Knowing we understand the risks that involve with the pH of that, and talking about even hyperchloremic acidemia, which is a whole nother road to go down. But bring them to us.
Let you fix that.
Let us fix
yeah.
it.
Yeah.
Sure.
No, I'll buy that. That's unfortunately in my mind, I hate the way that works.
Sure.
I'd rather. But yeah.
I hate having to give pressors to a patient I have intubated because I have a propofol drip. So I don't like propofol drips for that reason, because it doesn't make sense that I'm giving a medication to correct for a side effect for a sedative that I'm given. So
I think we've covered pretty much everything trauma that we could talk about today, right? Talked about different levels of centers, got to know Dr. Tinkoff a little bit better here.
I think this has been phenomenal. I really appreciate meeting you and
Oh, thanks.
and having this conversation.
I enjoyed it. Yes.
Did you? Good,
Yeah,
good.
I
We've enjoyed having you. Unless you think there's something else we should add about trauma care, or maybe something EMS could do to better improve patient care. Or
I think the only thing I add is that please support your trauma centers. Make sure you're involved, and make sure they're involved with you as organizations. The closer we can have involvement, the better we'll know each other and focus on our communities and serving our communities well. So
that's great.
Yeah.
Well, we'd like to thank you for coming out, Dr. Tinkoff. We give every one of our guests one of our
Fantastic. I love these
podcast challenge
Yeah.
coins.
Thank you.
So
Scott's not here
thank
to
you.
say it, but
Scott's
you
not here to
may
say
be able
it.
to redeem it amongst us for a beer, but nowhere else.
no actual
Beer or
cash-
bourbon?
No. These give me great pride. The first one I received was when I was at launch stool, and I keep these with me. I've got these from several institutions and hospitals, and I think it's the best gift any speaker can have. Thank you for doing that.
Yes, sir.
I didn't even know you had these.
Yeah.
These.
We try to be pretty bougie. Yeah, we try.
That's fantastic.
Well, thank you for everything, and I'd like to thank everyone for listening to our podcast, and you'll be catching us doing the live at some fire department somewhere in the future, so thank you for listening.